Yeah, Dr. Ipam, you can restart up. Yeah.
Okay. No. Thank you so much. And as I told you, am I audible? Bentley? Doctor?
Yeah. Yes, Doctor. Audible on a screen, visible on.
Okay, good. We have single tooth dental implants, or in that itself, nowadays we have so many different types. That is short implants, then they are very ideal for situations where there is very less vertical height and you have to place a tooth on that. And we have even narrow implants indicated for the lower anteriors and even for the lateral incisors with a smaller size. And there are different types of dental implants. With nowadays, implants are very well designed in a very biological fashion to accommodate more bone around it, to have crustal stability of bone, to have a better connection between the implants and the abutments, and to have a good biological feel, and to avoid screw loosening. We have so many different companies offering different types of connections. We have different companies offering you a very progressive threaded design, and the primary stability is really high with this type of implants. And it's like just like any other screws, not like nut and bolt. It is really just goes in and it stays there firmly and allowing an early osseointegration. And where we have to place the bone, place the implant, and what is the quality of bone we should have. Very ideally is D2 type of bone, that is a mix of cortical and cancellous type of bone. That is medullary bone area is adequate to give you the viable bone cells and good amount of cortical bone to hold the implant in place firmly. So anatomically, we can divide our areas in the jawbone into different areas like D2, D3, D4, and anterior mandible. I will say if you lose a central incisor in the lower anterior region and if you are trying to replace, that is the most difficult area because the viable bone cells are very less and it is all dense cortical bone. You will get good primary stability, but to get a secondary integration and to have good aesthetics in the anterior mandible region is really tough. And at the same time, the posterior mandible, that is our lower molar, that is the area where everyone should start placing the dental implant, and you should learn implantology is by placing dental implants in the lower molar region, especially towards the anteriors, that is the first molar. I train my students with placement of dental implants in molar region first. And then comes the anterior maxilla, aesthetically highly demanding. And you have different techniques nowadays to create aesthetics in the anterior maxillary area. The quality bone is adequate if you really condense it well, though it is more cancellous in nature than the posterior mandible. It will have good adequate stability. If you take care of the palatal bone and the nasal floor, you can gain good primary stability in this area too. The challenge is giving aesthetics with implants in the anterior maxilla. And in the posterior maxilla, most of the times the bone resorption is really faster and you will have less quantity of bone. Quantity and quality of bone is most of the times less in subsinus areas, that is below the sinus level in the maxillary region. The healing of an implant is like any other fracture healing with a callus formation. Then the osteoblasts coming in and then they are matured sites and then the osteoids are formed. Then the newly formed osteoid get maturation and adaptation. And by 6 weeks, that is 6 weeks, we get a soft tissue healing and osteofixation. But with the 3 months to 6 months time, you will get a secondary integration of bone all around. And the newly formed bone will have its strength in all possible ways and it will have good durability throughout the lifetime. And How we calculate the amount of bone in a clinical scenario? Previously, we all are used to measuring the depth and the inter arch distance and the prosthetic space available, and even the mesiodistal length and the buccolingual length, everything with an assumption. It was more of a guesswork. And most of the times we used to get fooled because of the thickness of the soft tissue, and the availability of bone is entirely different. When you open up the flap, that is the time you realize that the bone is very less. So we changed the scenario. We started practicing implantology from two-dimensional diagnosis to three-dimensional diagnosis. I'm fortunate to have a CBCT machine in my practice now. From last 5 years, we have that machine in our place. And with the help of CBCT, I think recently Pushpagiri College also got the CBCT unit, and I'm sure they're taking the implantology and the endodontics and all the other procedures to next level. See, with the help of intraoral scanner and that records the soft tissue component, and the CBCT records the hard tissues of jaws and the teeth, with both we can create a virtual patient in our computer. And you can virtually place an implant and see, if I place this dimension implant, where exactly it is going to stay, and how safe it is from the adjacent vital structures, and how good it is going to be in the prosthetic outcome. And you will know where exactly the emergence of that particular screw is in terms of the crown, what you are going to give. And now, let me say, many times we get fooled with the two-dimensional imaging. When we do that, you will think that there is a lot of space from the crestal bone to the inferior nerve, and around the 13 or 14 measurements it will give. That is 13 or 15 mm, sometimes 11 mm. But the actual reality is when you see the tooth section in a three-dimensional fashion, especially when you take a sagittal section, and when you try to place an implant, you will see that you have a hindrance after 7 to 8 millimeters, that your lingual cortex is coming in the way, and you will not be able to place the implant more than that depth. So either you will land up in giving the implant more into the prosthetic space and more towards the oral side, and you will not be able to go in depth, or otherwise you will perforate the lingual cortex and you will create bleeding from that side. So this is an article about the cone beam CT and its usage in clinical dentistry and in implantology. With the advent of CBCT in dental practice, the radiation dosage, what we have to give to a patient in order to get to the three-dimensional detailing of that particular area is very, very less compared to the regular CT scan what we have to perform. And with that, I can say that CBCT can be used as a regular tool in the diagnosis, treatment planning, and even in the execution of dental implant placement, like any other maxillofacial defect correction or any other surgical procedure. Now, let me take you through a scenario where I have to place dental implants in that edentulous area, and the patient restricted me to place the one implant first. Otherwise, I will prefer to give 6 and 7 in that region. But in this case, we have planned only 4, 6. And see the way we are planning. It is not in a two-dimensional fashion. It is absolutely in a three-dimensional way. How much it is separated from the buccal bone and the lingual bone, where exactly you have to place. And according to the future crown, where exactly the axial loading of that crown is to the implant, and that is the axial placement of implant to take up the maximum occlusal load, and how much it is mesiodistally separated from the adjacent tooth, and how it is placed in all 3 dimensions. So once you plan, you will be able to get the same result post-operative. And if you have adequate soft tissue thickness, and if you have placed your implants very well, that is in the exact depth what you need to be placing a dental implant, your crowns will not look like a hanging object. It will look like a very natural tooth emerging from the socket with all its emergence profile line, like any other natural tooth in your mouth. So that is about the single tooth placement. And I told you it is very difficult to create aesthetics in the anterior region. see this scenario, you have already lost. This patient came to me and asked me only one thing. I am getting married next in few months and you have to give me a tooth. But I don't want any artificial look in that area. You have to give me, and he gave me a free hand to do what I really wanted to do. And all the learning what I had in an aesthetic restoration of dental implant in the anterior zone. And I did a procedure called as a root membrane technique or socket shield. And that is by which I could preserve the tooth, the bone and the soft tissue contour around that missing tooth. And when you go through that, the placement of dental implant in the ideal position and recording that emergence profile, how the depth, how the tooth has to come out, and modifying the temporary crown in such a way that the tissues heal in a particular fashion. And as I told you, I used zirconia abutments to hold a lithium disilicate crown in place. And this is the result of what I could give to my patient. He's extremely happy and he thanked me several times for restoring it in the right way as he expected. And multiple dental implants, I showed you this picture. I selected only very few cases for this presentation because the time is very short and I wanted it to be very much just to the introduction of this subject and just to show you people some cases. This is the case what I showed you in the beginning where the patient would have landed up in a long span bridge. But extracting that tooth, that number 7, that second molar, which is having a vertical fracture and having a very bad prognosis with the root canal treatment and the crowns, we decided to extract that. And again, to go with one more implant in the edentulous area of 1-4. So 1-4, 1-5, 1-6, 1-7. All these crowns are given, that is 4-unit bridge is given with extraction of only one tooth and giving one short implant and one regular implant and immediately loading the site with the help of CT guided implant placement and guided surgery. And this is the result. I think it was a freehand surgery. Yes, I did it as a freehand option. And I didn't wait for long, only for the socket healing, only for the soft tissue healing. No grafts placed. And the result is the patient received a bridge in 6 weeks time, only 6 weeks. And the patient walks out with a wonderful bridge in his mouth. And this is the way we can reduce the span of your edentulous area and you can give predictable results with a limited amount of bone and with a clever understanding of the bone structure around it and a fine detailed execution giving you the ideal results. That is very predictable results. And I would like to show some of the overdentures to retain the denture. I talked about this. I could pick up some cases here and there. This is one of my former patients. He wanted to have a removable denture at any cost. And he placed 4 implants and gave an overdenture and a bar retained denture in the upper. And we have so many patients with locator attachments and multiple implants. And at times we prefer to give them removable options because of the cantilever scenarios and the prosthetic, the cost of the prosthesis too. Now, this is a condition where we replaced an arch dentition, that is the maxillary arch dentition, completely with the help of a gated scenario and implant planning and gated option. And this is the hybrid denture what I could deliver to the patient. None of the natural teeth in the lower is extracted. Implantology is not to just pluck out the teeth and replace them with implants and crowns just to make some more extra perks of money. It should be like preserve the maximum what you have and restore what is missing and rehabilitate whatever you can. That should be your principle in handling implantology. It is very difficult to create a occlusion balancing with the natural dentition, but we gained this and the patient is perfectly fine with his chewing and he is very much, I think it is more than 1.5 to 2 years now that we did this procedure. When all the teeth are lost, we have options like All-on-4, All-on-6. You can have multiple teeth extra, but to be economical at the same time, very predictable option is All-on-4. And we have fixed dentition given above that with hybrid dentures. Just like any other complete denture, we have to give the jogulation, and then the implants, and two tilted and two straight, and taking the measurements of it in a digital way or in a manual way. And this is the way we can give a full dentition. And the results, what we have with such a treatment protocol and the patients enjoying, like I told you, the candy or whatever they chew with, the nuts and cereals, what they eat and what they enjoy. And most of our patients come and say me that, doctor, I was very happy to have my banana chips and these on uperi and all these things. Like I say, okay, fine. And that is the time I realized that what does the implant-based fixed solution gives a solution to a patient over a removable prosthesis or a RPD or any other mode of treatment option. And when nothing is left, when you don't have any bone in the dentition, still your patient needs to have a fixed option. Then as a surgeon and many of my colleagues, even in other specialties, they do zygomatic implants. Two zygomatic implants and one or two implants in the anterior region, that is good enough to give a full mouth dentition. And even worse than that scenario, when there is nothing left in any of the zones of the maxilla or in the maxilla, that is the time we opt for something called a Scott zygoma. I will share a very touching case, like it is something very close to my heart, a scenario where I replaced all the teeth of my friend. He is of my age. He was my dental technician when I was doing my dental education. That is, when I was doing my BDS, he was in our college as a dental technician. Then he moved to Middle East. Then he moved to some other African country, and he worked for a long time. And he lost all his teeth because of his periodontal disease. And I'm sharing this case, what I have done for him. So that is the maximum what we can do for a patient of your own with predictable results, and giving him his chewing and all the aesthetics back to him, and restoring him back to the normal life. What he had a lot of trouble with his loose teeth and so on. He had many. Hello. Am I audible, Dr. Bentley? Hello. Hello. Can you hear me?
Yes, sir.
Okay, that is what I just wanted to know. Like, okay. So I told you about what we can do in the worst scenarios, like where there is maximum amount of bone loss. And nowadays, like any other subjects, we are going completely digital protocols. It makes our life easy and faster. We have very predictable solutions with implantology too, in case of digital protocols. I was talking about so much of planning and then executing the thing. Nowadays, I hardly take 20% of my clinical time for execution, and 80% we leave it for the planning. And that is most of the time done by my colleagues. And then we come into the right scenario and we give them only some instructions. Okay, do like this, do like that. And they together as a team, we work and they plan the implants in the software, and that reduce my clinical hours a lot. I'll just take you through the steps. I don't want you to get into that in the initial stages of your practice, but you have to understand that there is a possibility of virtually creating a patient and doing that surgery. And it is 1:1 this on a precise fashion. We can create a surgical gate and you can go to the right depth without endangering any of the vital structures, and you can get the right results. Like there is no manual error you can have. And this is very predictable if you know the right steps in planning and creating a gate. There are several ways you can create errors even in this. But if you are really trained to do this, you will create this surgical gates and you will give dental implants with a high accuracy and good parallelism and very predictable results in terms of dental restorations. See, I think I have taken you through the various possibilities of usage of dental implants. And like I always say, every next level of your life will demand a different you from your side. You have to raise yourself to the expectation of others as a clinician, as a specialist, as a good colleague who can give support to your own friends. And every time you learn something new, you have to teach the same to others. You have to be a good learner. You have to be a good performer. You have to be a good teacher, and you have to be a good mentor. I missed many times a good mentor and a good this on peer group to support me. So with a lot of hardship, I learned this on techniques and protocols. But nowadays, very happily, I train my team, and with my team, I perform much more than my expectations were, because they have created such a good platform for me that I can rely on them, and they do the entire protocols hand to hand and shoulder to shoulder. They are the pillars of our practice. So you younger generation dentists, please take good training in all these protocols: implantology, cosmetic dentistry, digital dentistry, the areas where you can gain your knowledge and you can show your expertise is very vast in dentistry. Dentistry is much more creative and vibrant than many other specialties in medicine and surgery, I will tell you. If you have the passion, if you have the patience to learn and perform and refine yourself,
5 o'clock.
Then there is no looking back in your profession. Many people look at dentistry as very challenging field nowadays. There is no much opportunity, or you have to create your own opportunities and your own place in your profession. That is your job. No one will gift you that. With these words, I think if I could inculcate any good things in these young brains, I'm very happy, and I look forward to see you all as good clinicians. And I will be always available for any help. You can mail me or you can call me. Sorry, I didn't share my numbers in this, but you can take it from your teachers. And actually, I got elected as president of one of the prestigious academies of this country, that is ISCD. From yesterday onwards, I am in this position, and this is the team what I am working with in the cosmetic dentistry area. The cosmetic dentistry, cosmetic surgeries, implant-based solutions, technology-driven dental practice, this is a dream come true for me. And I invite you all to this successful dentistry and career ahead. And I would like to have some more programs with you all in Pushpagiri Dental College in the banner of ISCD. And I have already spoke to your teachers and your principal and vice principal. I'm sure we are going to meet again with a different subject in dentistry, mostly that is in cosmetic dentistry, and the cosmetic dental thought, that is making your dentistry more cosmetic and acceptable to the patient. What are the challenges you have and what are the ways you can tackle that scenario, making it a wow factor in patient's mind and your colleagues. That is what we wanted to teach you in coming years. I think your college is going to take up that challenge too. Thank you so much, dears. Thanks for having me with you all. And I enjoy teaching the younger generation rather than teaching to my own colleagues of my own age. I think I have done justice to the topic, just the introduction of this basic protocol with the dental implants, a viable value-added option. Thank you so much.
Yeah, and Dr. Sagan, thank you very much for the wonderful presentation. It was really very good for our students, especially we know that oral implantology cannot be taught in one day. Okay, so you have put everything in a nutshell, and it is given a good idea to our students who are not aware about the reality of dental implants, which is the current real scenario in dental treatments among the patients. Unlike the earlier times when patients did not opt for dental treatments, but now patients are opting for dental treatments in a very regular scenario. So thank you very much, Dr. Sagan, for the wonderful presentation. Now, Steffi, if there is any queries from our students, you can put it up.
Please, dear friends. Any questions? I was the one who used to ask all foolish questions to my professors.
Yeah, quite. I think the students usually they are shy enough to ask questions, so that is fine. Yeah, and Dr. Reno, I think you can conclude the session.
Okay. Good evening to one and all. It's my privilege to propose a vote of thanks. On behalf of Department of Public Health Dentistry, I take this opportunity to express my gratitude to a renowned speaker, Dr. Sagan Chandran, for his excellent presentation, which has enlightened our students. It was a very relevant topic. Anyway, thank you so much, sir. And I would like to thank Dr. Millie George, Vice Principal and Head of the Department, for his constant support. Also, I express my gratitude to third years and final years. And my special thanks to the coordinator, Dr. Steffi Sajan. Anyway, thank you all.
So once again, thank you very much, Dr. Sagan. We look forward to have more cosmetology programs in our college also. And like you have already mentioned, you are the president of it. So we'll definitely have some offline and online programs on cosmetic dentistry for our students. Yeah. So it was really.
Thank you, Dr. Benley.
Yeah.
We will be in touch.
Yeah. Thank you. Thank you very much. So we can wind up this session. Thank you.
Good evening to one and
Yeah.
all. Enjoy your day.
Yeah. Thank you. Yeah.
Thank you, sir.
Yeah.